Thank you very much, Farah. So for our final presentation for session 1 this morning, I'd like to welcome Dr. Gina Marcela Torres. Dr. Gina is of Urology, Abu Dhabi Stem Cell Centre and consultant at Al Ain Fertility Centre. Dr. Gina has a bachelor's degree in medicine from the University of Rosario, Colombia from 2002, a master's degree in urology since 2010 from Spain, PhD since 2015, achieved in Spain. Dr. Gina is European Board of Urology certified since 2018, and she's currently working in Abu Dhabi Stem Cell Centre in UAE. Please welcome Dr. Gina.
Good day, everybody. I would like to thank the moderators of this conference, especially to Mediclinic, who launched this interesting meeting for every scientific in the country. I am Dr. Gina Torres. I am consultant urologist working at ADSCC, and I've been working here in the UAE since the last 2 years. Today, I would like to share with you our outcomes after given the stem cell treatment for the COVID pandemic through nebulizations.
This presentation was created to characterize the acute renal injury in patients with COVID-19 and the relation with the clinical outcomes, interpretation of the laboratories after giving the treatment in the cases group or after inclusion in the control group, in order to know if the stem cell treatment changed the course of the disease and related complications. As we all know, the COVID-19 pandemic is an unprecedented challenge. As part of the effort to find a treatment for this disease, the research team from ADSCC proposed the use of autologous stem cell through nebulization with the use of non-hematopoietic peripheral blood stem cell due to their safety profile and their immunomodulatory capacities. Also, as we know now, the virus and their related complications affect the urinary tract and kidney function, and it could be mediated by the ACE2 receptor and found up to 4% in the proximal convoluted tubules, but also by the septic shock and cytokine storm syndrome or the immune-mediated kidney damage. During the month of April and May in 2020, the Sentado COVID clinical trial was done, comparing the Group A cases group with the Group B control group. We categorized the severity of the disease following the scale created by the WHO, and then we did this prospective and analytical study to determine the impact of the disease in the renal function and the efficacy of the therapy in the treated patients. The demographic data from all the patients was collected, included gender, age, BMI, comorbidities, and vital signs, as well as the biochemical studies, which were performed within the 24 hours of the inclusion in the trial, recording the plasma and serum-based biomarker concentrations, including the CRP, IL-6, D-dimer, creatinine, and the impact of the lymphopenia. When I saw this data, as urologist, I thought about using the neutrophil lymphocyte ratio that we use for assess the mortality risk in disease like renal cancer, using a cut point above 3. Both groups receive standard treatment as per the national guidelines for COVID-19. The patients from cases group received as well a nebulization with stem cells. In this slide, you can see a picture of the used cell for this treatment. The trial was complete with a total of 139 patients, 69 from the cases and 70 from the control group. At the ICU. assigned as critical. That means scores 5 to 7. 23 were from the controls and 20 from the cases group. All these critical patients were males with an average age of 49-year-old, in the cases group an average age of 40. ratio. Regarding the hospital stay, even though the media didn't rise at significant difference, we can see that patients from the cases group were more homogeneous compared with the controls. Having a hospital stay from 10 to 43 days, while the controls had a hospital stay from 11 between the groups regarding the sepsis episodes, which were less in the cases group. No difference were found in the hemodialysis requirements or creatinine values. As I just said, more patients from the control group suffered from sepsis compared with the cases group, with a hazard ratio of 0.38, suggesting an NNT or number needed to treat of 2.5 patients to avoid these episodes of sepsis. It's also important to note that the most common pathogen causing sepsis was Candida albicans, followed by Streptococcus pneumonia, Pseudomonas aeruginosa, Klebsiella pneumonia, Enterobacter aerogenes, and Staphylococcus aureus. Also, we found significant differences favoring cases group regarding the CRP, which dropped drastically after the treatment, and also the lymphocyte count was improved. We didn't find any other significant difference regarding the rest of the parameters. So we conclude that the hospital stay, mortality, and especially the sepsis were less in the cases group, who had a shorter range of hospital stay compared with the control group, and that fact may against nosocomial infections. And even though the cases group had a higher risk of mortality at the inclusion of the trial due to their neutrophil lymphocyte ratio, the treatment improves drastically the parameter due to their lymphocyte count improvement. From the 43 patients included in this analysis, 1/3 of the patients suffered from acute renal failure and required hemodialysis. The patients of the treated group showed a better tendency to improve than those in the control group. And understanding the pathophysiology of the kidney failure, we can provide possible therapeutic strategies using the immunomodulatory effect of the stem cells that offers a great promise for the management of this illness and can become an important therapeutic tool in combination with other supportive treatments. Finally, I would like to thank to all our colleagues that are working to fight this terrible disease, and especially to the Ceja hospitals who help us and believe in our treatment. Also to all the scientific teams that are working to find new therapies for this pandemic and creating new tools for the future. Thank you very much and have a great day.
Thank you very much, Dr. Gina. So we're going to go into a short question and answer session. We have a few questions from our online participants. Okay. And our final question is for Dr. Gina. Is acute kidney injury in patients with COVID-19 considered a marker of disease severity and a negative prognostic factor for survival?
Yes, actually in the Wuhan studies, they showed that the kidney injury was found in 25% of the population with COVID-19. That could be because of the virus, because the direct damage because of the virus, but also because all the treatment that the patients are receiving that can damage the kidney as well. So this is really important to take in account because sometimes, because of the lack of time and human resources, in some countries, some places, they forget about this special disease. And when in our study, we found that 25% of the cases had a kidney injury and 35% of the controls. So that also can be the reason of why the control cases stay longer at the hospitals. So it's really an important damage, an important consideration to take in account, because not only the lung is suffering with the COVID, not only the thrombosis that is causing in the lung, it's because the cytokine storm is damaging all the organs and especially the kidney. So as urologist, I was focusing in this part, and I think it's really important to take in account.
Brilliant, thank you so much. So that's going to conclude our first session this morning. Thank you so much to our speakers. You've done a fantastic job. We're going to take a short break and we'll reconvene at 10:45, please, for our session 2. Thank you so much.